No, thank you for the introduction, Dr. Varga. I appreciate the opportunity to speak here. I think pain management for small ruminant species is something that we're seeing, more and more interest in, more and more developments in, not just in the drugs, but in the techniques. So look forward to sharing some of the stuff we're doing and talking about some of the approaches that we have. So the outline for what we're going to do today is, we're going to talk a little bit about pain with both like the underlying mechanisms or pathophysiology of it, and then observation of pain. We'll talk about the different analgesic or pain relieving drugs, some of the tools for pain management that aren't necessarily drugs, or maybe specific ways we can apply those drugs. Because we are dealing with what is considered in the US to be a food animal species. We'll talk a little bit about regulatory concerns, and then we will conclude and have some time for questions at the end. So I just brief introduction of myself. I'm from Pennsylvania, went to vet school at Ohio State, did a master's when I was in practice after vet school, went to UC Davis and did a large animal internal medicine residency. And that's where the picture on the screen here was taken. I went out on a farm call with Dr. Varga to deliver a camel calf. And I'm assuming that's the traditional happy European live calf camel dance in the background that Dr. Varga is doing there. From UC Davis, I developed an interest in pharmacology and I did some training there. And right now I'm a faculty member at the University of Tennessee. I'm in the clinic, I'm doing research, I'm teaching our pharmacology course, and on a day-to-day basis, I'm kind of pushing around large animals, trying to teach students, try to keep students from getting hurt. And I'm also one of our wrestling coaches where I push around large animals, try to teach students, and try to keep students from getting hurt. So just back to the topic at hand, sheep and goats, we're seeing an incredible increase in their popularity in the United States compared to even several decades ago. And what's kind of unique here is we're seeing production, small ruminants that are for meat, milk, or fiber production, but we're also seeing companions that are fitting the role maybe of pets that traditionally a few decades ago we would have seen like a cat or a dog being filled. And there definitely is demand for pain management for a variety of circumstances, some of which are our traditional needs like surgeries. But then we're also starting to see with this companion animal population, a need for other methods of pain management, like for osteoarthritis and older companion animals and things like that. So it's definitely an interesting time for pain management, sheep and goats. To go back into our introduction here, we have our definition of pain, which is typically an unpleasant sensory or emotional experience that will elicit protective motor actions from the nervous system, potentially result in learned avoidance, and is capable of modifying specific behavior, including social behavior. When I think about pain, there's 4 different steps for pain. And the reason I'm bringing this up is because each one of these steps is a potential opportunity to break the cycle for pain. And so the first step is transduction, and that would be this red or painful stimulus on the hock of this goat here. And I have these boxes here because it shows where some of the different drugs that we could use could potentially fit in to manage pain. So at this first step of transduction, we could use local anesthetics, potentially regional anesthetics, or opioid drugs, our alpha-2 agonists, although we typically use those more for sedation or tranquilization, and then our non-steroidal anti-inflammatory drugs. The next step is transmission. So we have the site where the painful stimulus occurs, and then it needs to travel up the nerves towards the spinal cord. And we could use, again, anesthesia here, predominantly local anesthesia, but regional anesthesia could block, the transmission of pain. For our next step, when we get to the spinal cord, is where we're going to have more approaches for like our opioids or local anesthetics again. Sedatives could be used here. When I talk about our dissociative anesthetics, the only real drug we have that fits that category in vet med right now is ketamine. And we're starting to see from the small animal side of things, these ketamine vacations, or maybe animals with chronic pain, they'll do a little bit of ketamine therapy. They're doing similar things for people with chronic pain and I think depression issues as well. And then finally, we get the projection of pain, to the brain from the spinal cord. And this is something that this is the only area where local anesthetics don't work, but we could use things like opioids or injectable anesthetics and our other sedatives for this. One of the things that I think is more and more unique and interesting in veterinary medicine is pain management is something that we're seeing our new graduates being asked to be very proactive and very assertive when they get into their first jobs. It seems like pain management is maybe, I don't want to say a newer focus, but a more recent focus for vet med. And it seems like the older generation of veterinarians kind of appreciate this. And I think it's a neat opportunity for some of our newer graduates, when they go to practices, they might be working with someone that's 20, 30 years older than them, and they're kind of leading the way and kind of demonstrating some of the newer techniques for pain management. So from here, I want to go towards the observation of pain. This has some unique challenges for sheep and goats. If we think about painful behaviors, if we have pain from lameness or like a musculoskeletal injury, we might have altered function, like the guarding of a limb. We potentially could see an increase in fearful behaviors, such as flight, or maybe even we notice like reduced appetite. And this is kind of one of the challenges for recognition of pain in goats and sheep, because they descended from prey species initially, so they're not really programmed to show pain very well. So often by the time we see pain or evidence of pain, we often have an animal that's fairly far along in this painful process. So, problems we have with this approach is just that by the time we can see these types of physical indications of pain, it might be a little bit more advanced as far as the development of whatever the painful stimulus is. We might be starting to see some of these behaviors already that we talked about earlier, and it might be a little bit more advanced to treat. Painful behaviors, we can see anorexia or just a reduction or refusal to eat. Often when we're looking at gastrointestinal conditions or abdominal conditions, we'll see this hunched posture this little guy in the middle is demonstrating. This can be an indication for visceral pain or pain of the abdominal organs. And then we can also see painful animals be more likely to run away and exhibit flighty behaviors. One of the challenges we have is, as clinicians, is how do we measure pain? And we kind of have some, research-based techniques that we can use. Things like substance P concentrations or cortisol substance concentrations. There's some mechanical tests we could do, like the nociceptive threshold. We could look at prostaglandin concentrations and decreases. One of the things that's increasing in its application, but really isn't quite on a day-to-day in the stall or on the farm test, is pain scores and scales. And so some of the issues we have with these approaches, these are more applicable for like research settings, not necessarily stall side with the animal in the hospital or with the animal in front of us in the barn or out on the farm. But just to go over some of these things in case you hear them mentioned, cortisol is a hormone that is a physiological indicator of distress or stress in cattle. We have seen some recent increase in the use of cortisol levels in small ruminants. And the assumption that we're making here is that we have an increase in cortisol that's going to be due to stress. And if we see an increase in stress due to a potentially painful stimulus, that's going to mean we have more pain. And we do know that the secretion of cortisol can be altered by analgesia. So if we have a painful stimulus to an animal and we give them an analgesic or pain dampening drug, we should see a decrease in that cortisol response. One of the more recent ones that we're seeing used is substance P, and this is a neurotransmitter in the central nervous system. It can be involved with behavior, anxiety, also to a lesser extent nausea and emesis, but that's more of a dog and cat and human thing than it is in small ruminants for the nausea and emesis. It can transmit nervous system signals as well as modulate them. So if we have a painful stimuli, especially inflammatory pain, we expect increases for substance P. Pressure algometry is a technique where we'll sometimes refer to as mechanical nociceptive threshold, and it's basically a measurement of the amount of pressure necessary to respond to a stimulus. And one of the examples here I think we have in that image there in the bottom right of the screen is we had calves that were disbuttered or dehorned, and the device, which is in the upper right-hand part of the screen, was placed on that site. And the thought being, the more painful an animal was at that disbudding site, the less pressure it would take to get a reaction. And so we can see on that device there is the rod on the beginning of it, which is the pressure sensitive part of it, and then we have that display. And so the thought is, like, if we have a painful condition, we can use one of these, and the lower the response to elicit, or the lower amount of force to elicit a response, is going to be an indication of a more painful animal. The downside we have with this one is that if we're doing it, especially in these repetitive research settings, the animals can become conditioned. So they kind of learn, hey, as soon as I flinch when they put this thing on me, they stop poking me. So sometimes it gets a little bit harder to discern this data after multiple applications. Prostaglandin, we'll talk about this a little bit later when we talk about the non-steroidals, but when we have injured tissues, especially from inflammation, we'll see increase in prostaglandin. And this prostaglandin, in addition to causing like local inflammation, can also sensitize some of the nervous system receptors that are going to be responsible for pain. So if they get sensitized from exposure to prostaglandin, it's going to enhance pain transmission. And this is actually a protective mechanism, because if we have part of the body that's damaged, pain is something that keeps us from using it, or keeps us from putting like a lot of pressure on it. So there is a role for this prostaglandin. Unfortunately, when we start to see increased levels of it, we do see more pain. One area that is coming along pretty quickly now, and that I'm really hoping we're going to see more applications in the future, are these scores and scales. And I have a picture here of like one of the pain scores that like people will use in the doctor's office. And unfortunately, our sheep and goats aren't being able to tell us like how they're feeling, but it's on like a 0 to 10 basis. But we are starting to see applications of this with like grimace scoring and facial scoring. And we don't quite have, like as a research community, all the kinks worked out of this yet. But I think it's just a matter of time until we have, the ability to look at these features, maybe with like a smartphone app. And maybe we'd use like facial recognition software, like what they're using now in the smartphones already. And, potentially that could be like an on-the-farm tool, or, in the stall tool to determine how painful an animal is. The most work as far as small ruminants go with like the grimace scales and facial scoring is with sheep, and they'll look for things like the posture of the ears, the tightening of the space between the eyes, features with the mouth and nose, like alterations in the cheeks. So these are all things that we can look at too as well, but again, it's going to be more from a research setting. Other things we'll look at will be movement analysis. There's accelerometers, which can measure the patient in three axes. And essentially, when things like these are used, the thought is an animal that's experiencing more pain is going to move less, and we can use these devices to log that. There's pressure mat or force plate. If we're dealing with pain from lameness, we might see an altered gait, or there might be one limb where the animal is putting less pressure on just because it's sensitive from the pain. So this would be another way we could test it in a research setting. There are some social aspects to these as well. We will sometimes see when pedometers are used that just simply measure the number of steps that a lot of our small ruminants like to congregate together. And so we might have, if we have a group of animals and some are exposed to painful stimulus and some are not, they might just all stay or choose to stay together, or if they have to migrate to like a water tank or a feed trough or something like that, that might alter how much they're going to move. So there can be other aspects to this that can interfere with observation of pain. But one of the key things here is that we want to anticipate and predict pain wherever possible. And so we could be doing a routine procedure like a tail docking, a castration, disbudding, and pretty much if we're going to be damaging tissue, we can anticipate that there's going to be pain. So we should think about what steps we can take to mitigate that. And also our non-routine procedures, things like dystocias, deliveries, things along those lines. If we have traumatic injuries, think if we can anticipate pain, what type of pain and what we could use for it. One of the phenomenon that I keep in mind more and more as I've gone in my career is what we call nociceptive windup. And basically, this is part of that protective mechanism for pain, where if we have a painful stimulus, the body gets kind of hypersensitized to it. And the key here is to reduce this whenever possible. And this is where sometimes in the earlier stages, if we can get like a non-steroidal anti-inflammatory on board or some pain medication on board early, it's going to take a lot less overall to make the animal comfortable, or potentially using a drug, before surgery, so we get it built up in the tissues, so we have less inflammation during surgery, could lead us to a less, painful outcome in the end. One of the resources that I used a lot earlier in my career, and I still use, is from the School of Edinburgh in the UK, and they have a whole website on guidelines, recognition, and how to assess animal pain, especially for livestock. So there's quite a bit of good resources here. I like to use this site. I'll direct students to this site, and just shows you some of the behavior. They've got some quizzes and questions for you here too. So from here, we've kind of talked about the mechanisms for pain and the observation of pain. And I wanted to get into some of the analgesic drugs or pain relieving medications that we're using. So when I think about like a food animal, and I know we have some companion goats and sheep too, but if we're thinking about like a food animal or typically a large animal, what would make for an ideal pain reliever? So it's going to be something that's easy to administer. If we have these large animals or animals that can be faster than us, we don't want to be chasing them down to give an injection all the time. We want something that's going to be very well absorbed. And one of the terms we'll use for that is high bioavailability. So if we administer it orally, we want to make sure it's absorbed. When we get to our adult sheep and goats, the rumen can sometimes be a barrier for absorption of medications because it can dilute them, and there's all kinds of microbial processes there that can sometimes start to break the drug down before it can be absorbed. We do need it to be effective, so something that's easy to administer and highly bioavailable isn't going to be very useful if it doesn't work. And in theory, because we're dealing with large animals, we want something that's going to be not terribly expensive, although this necessarily wouldn't apply to some of the companion sheep and goats we're starting to see become more and more popular. And one of the drugs that really fits this category is our non-steroidal anti-inflammatory drugs, similar to like ibuprofen or naproxen for people. We have a whole class of these that we'll use in livestock and can be quite effective. And so just to go through the mechanism, these green squiggles and circles at the top there are going to represent the membrane that goes around every cell. And we can have an insult in that membrane, and that can be injury, that can be endotoxin, infection, or trauma. When we have that, it's going to damage the cell lipid or the cell membrane lipid layer, and we're going to see some breakdown products. And the first step that is going to happen here is going to be broken down to arachidonic acid. And one of the drugs that could potentially stop this step are steroids. We don't typically think of those as pain relieving, but they are definitely going to be anti-inflammatory drugs. And then from there, we have a couple different ways that arachidonic acid can go that can lead to things that are going to lead to pain and inflammation. And there's 3 enzymes. There's cyclooxygenase 1, cyclooxygenase 2, and 5-lipoxygenase. And depending on which one of these enzymes is activated, we're going to have stuff produced like leukotrienes, prostaglandins, thromboxanes. Some of these have normal physiologic function, and some of these are going to be leading more towards pain or adverse effects. And when I think about the non-steroidal anti-inflammatories, we have our ones that are less selective, and this is going to be stuff like aspirin, flunixin or banamine, phenylbutazone, and meloxicam. I have the Canadian flag there because our Canadian colleagues have a labeled meloxicam product for large animals. We don't have that in the US yet. We're using the human generic. But these drugs are going to minimize inflammation by interfering with these cyclooxygenase enzymes and leading to less prostaglandin formation. We have another drug that's recently been reintroduced into the US market called ketoprofen that has cyclooxygenase activity as well as 5-lipoxygenase activity, and that's going to be ketoprofen. And then we also have a newer class of drugs that are COX-2 selective. And the difference between like the cyclooxygenase 1 and cyclooxygenase 2, or COX-1 and COX-2, is that COX-2 by far and large produces more of the inflammatory end products. And COX-1 produces more of the things that we need for like everyday function. So to have a non-steroidal that focuses predominantly on COX-2 is going to be more beneficial for pain relief. And even those earlier ones I showed that had activity in both, some of those are predominantly more COX-2 than COX-1, but we have these newer class of drugs like daracoxib and firocoxib that are exclusively COX-2 limiting. So just the inflammatory prostaglandins get suppressed. One of the drugs I find myself using on a daily basis in my patients in the hospital is meloxicam. Now, This was originally developed for orthopedic pain in people for osteoarthritis. It's somewhat selective because although it has a fair amount of that COX-2 activity, it can still have some of that cyclooxygenase 1. This is orally administered in the United States. There are injectable formulations of this, but nothing that's labeled for sheep and goats. The dose is typically something like 0.5 to 1 mg per kg daily orally. If we do have llamas or alpacas, they absorb this so well that we typically go every 72 hours. And the recommendations for this as far as oral administration are kind of all over the place, but the key is like once you get an effective level, you want to reduce the amount that you're giving to the lowest amount that's still going to give you that pain relief or the efficacious nature that you need. We can see adverse effects with meloxicam, although it's thought to be a lot less reactive as compared to some of our other non-steroidals. Castration, disbudding, dystocia, C-sections, lamenesses. One thing I've started doing recently after I saw a paper about calves that were born during dystocia doing better if they were treated with meloxicam was if I have a C-section or dystocia, I treat the kid or the lamb. Because I think we often think about, the dam or the mom there, but, being pulled out anyway other than what you're supposed to be can be pretty painful as well. The pros of meloxicam is it can be incredibly cheap. Depending on what your supplier is, sometimes you can treat 45 kilograms of an animal for less than 20 cents a day, supplier dependent. Adverse effects, we can see gastric ulceration or abomasal ulcers. Typically, this is going to be after a long dosing regimen. And if we're dealing with production food animals, this can have a moderate to long withdrawal time. Some of the current recommendations from FARAD are about 30 to 32 days. The one downside with meloxicam is some of our non-steroidals are very good at relieving fever or pyrexia, and we do not see that very well with meloxicam. So things like flunixin are going to do a much better job of bringing down a fever than meloxicam is going to be. But meloxicam does appear to be safer for an extended period of time compared to things like flunixin. So flunixin, one of the brand names is Banamine, although there's quite a few generics out there now. Somewhat selective, so predominant COX-2, but some COX-1 activity as well. This is all bovine or swine labels, so we don't have a specific product that's labeled for small ruminants with flunixin. And we have pyrexia from respiratory disease and mastitis, and then hoof rot pain for the transdermal formulation. And so we have a couple different labeled formulations for cattle in the US. The traditional one is IV. There's a newer product in the past 5 years. It's a pour-on or transdermal. And there are some subcutaneously administered ones under the skin, but those are going to be like the two that are pictured in the bottom of the screen, the Hexasol or Resflor. Typically, they're a combination product with an antibiotic, and by giving that injection, you give both. If we give the IV, it can be effective and economical. It can be less than a quarter of a mil, but we do have adverse effects with this one because it's more likely to have adverse effects with like abomasal ulceration or kidney damage. We can be limited with multiple applications, and we do have to worry about like the safety. Like in cattle, when the transdermal formulation is used, they recommend you wear long sleeves and eye protection because it can be damaging to human skin. There's also a question when we're using these extra label, what about if we use it under the skin or intramuscularly? And there's some horror stories out there when they give this drug intramuscularly or subcutaneously to horses, because it can cause a myositis or inflammation of the muscle that can get pretty nasty. Other NSAIDs, aspirin has been around for a very long time. It doesn't actually have a drug label. It has a designation of GRAS, which means generally recognized as safe. And there's not really a lot of studies out there showing that aspirin, like what we get at the feed store, has pain relieving properties. So it has some anti-inflammatory effects, but not a very potent pain reliever. Phenylbutazone used to be used a lot more frequently than it is now. There are some safety concerns with small ruminants. It can cause some blood dyscrasias, and there is a concern for production animal species that if you have a residue of this in the food chain, it's not going to be a good thing. So I don't typically use either of these anymore. There are some newer NSAIDs like carprofen, marketed as Rimadyl for dogs. There's generic now, and there's been data to show after a claw amputation that this could provide analgesic properties. And then firocoxib is going to be one of those very selective COX-2 inhibitors. They're there's been a couple studies that show initially promising, especially from like a once daily oral dosing, but we need a little bit more studies just to dial down the dose and the indications for using these on a more widespread. So the two options we have that are used quite frequently are going to be flunixin, dose anywhere from 1.1 to 2.2 mg per kg. There is some research we can give this subcutaneously in goats. Key thing with this one though, not labeled for goats or sheep, but we typically have a short withdrawal time if we use it. And then the other one that we're using more commonly is meloxicam. Again, this can be quite economical. We're typically using this orally, but this could give us, if we have a production, sheep or goat, a longer withdrawal time. Sometimes we can be in like the 30, 32 days before it's safe to send them to slaughter. One of the questions we get quite a bit is co-administration. And on the small animal side of things with dogs and cats, they typically do not like going from one non-steroidal to another non-steroidal without a washout period. It's not uncommon for us in my practice setting, especially with our surgical patients, to give the first NSAID injection. So we might give a dose of flunixin injectable for the first dose and then follow that up after the surgery with meloxicam orally. We don't have like a ton of data yet, but it does appear that if it's just one dose of flunixin, that it is safe to follow it up with meloxicam. But if we do give multiple doses, we try to do a washout period just to give the body a little bit of time to clear the first NSAID before it starts to see the effects of the second one. One of the questions we get quite a bit is using like the transdermal product in sheep and goats. So this was introduced to the US market around 2017. It's labeled for beef and dairy cattle. Very convenient. You just pour it on the top line. It is a higher dose just because it's not as well absorbed as it is by injection. And there's been a couple studies looking at small ruminants, and one of them was done out of Kansas State where they compared it to the IV dose, and they found the bioavailability or amount that was absorbed was only about 25% compared to the IV dose. So you'd have to pour quite a bit of it on there to get that same effect of the IV dosing, which is going to be a safety issue. It's going to be expensive, and the efficacy wasn't necessarily as good with respect to what it did with suppressing prostaglandin. And then there was a study done at the University of Tennessee, it was done before I got here, where they did look at it for castrating goats. And they found that like it did help mitigate pain, but a single dose probably isn't going to be enough. And it wasn't as good as, flunixin by injection. One of the projects we worked at when I was at UC Davis was, giving flunixin by an IV injection can be a little bit technically challenging. It can also be limiting if you don't have a catheter to give it multiple times. And so we looked at giving it under the skin to lactating dairy goats. And we gave like a single dose, and then we gave 6 doses every 12 hours, so over 3 days. And we gave them kind of in this region behind the elbow, up a little bit on the rib cage. And the pharmacokinetics, like the tissue concentrations, were very similar to what we had with the IV injection, and we didn't have any adverse effects. So I don't know if this drug would be safe to give subcutaneously for months at a time, but in these lactating dairy goats we had 8 in our study group. We definitely saw multiple dosings, like about 6 doses total, and we didn't have any adverse effects like it would report in horses. So I feel a little bit safer about giving flunixin subcutaneously to goats after doing that project. One of the other NSAIDs that's recently been introduced to the US market is ketoprofen, and it's also available in the new Draxxin product that's been released recently. And so the Draxxin KP has an antibiotic, which is thromycin, as well as an anti-inflammatory with ketoprofen. I have not had the chance to use this that much in small ruminants. It's kind of harder to get our institutional pharmacy to put this on our shelves, but I'm looking forward to being able to use this more in the future. One of the adverse effects that we do see with our NSAIDs is abomasal ulceration, kind of like a gastric ulcer in a person from stress. These can be challenging to see because the clinical signs are often pretty vague. The animal might just be off feed. We might see grinding of the teeth. They just might not be doing well. They might be selecting hay instead of grain. And with ruminants, like sheep and goats, these are hard things to diagnose. If this was a horse or dog or a cat, we could just fast them and put a tube in there and just visualize it with an endoscope. We can't do that with a ruminant because there's no way to completely evacuate the rumen. And so we'll do fecal occult blood testing, where basically we'll look for some of the blood from that ulcer in the feces. And it's not the best test. Like, we have a lot of strength in a positive test, but we don't really trust a negative one. I'll go through this next one pretty quickly because it's getting a little bit off topic, but there are some gastroprotectants we can use in these species. Famotidine has been looked at in steers. Pantoprazole is a drug that my group has been looking at quite a bit in sheep and goats. We also have coating agents as well. One of the questions that comes up occasionally is with NSAIDs and anesthesia. Do we want to pre-medicate before surgery? I've worked with one anesthesiologist that she was not a fan, because one of the things the NSAIDs can potentially do is reduce blood flow to the kidneys. That's pretty much been the only exception, though, because as long as the patient is hydrated, you don't really have to worry about that as much. So if you have fluid support, if the animal's properly hydrated, I typically don't worry as much about an NSAID before anesthesia. Although, if we have a shocky patient or someone that's otherwise compromised, that might be something we have to watch out for. But generally, the benefit of decreasing that nociceptive windup is going to far outweigh the concern for the kidneys if we have a hydrated patient. Some newer drugs that hopefully we'll be using a little bit in the future are these prostaglandin receptor antagonists. So where our normal NSAIDs kind of block out the activity of the enzyme completely, what these drugs do, and the one we have in VetMed right now is galaprant or graboprant, is they bind to that receptor that the prostaglandin acts on. So when they bind to it, even though that prostaglandin is produced with inflammation, it can't work. Basically, by knocking out that receptor, you can produce as much prostaglandin as you want, but it's not going to be able to act because the receptor is going to be knocked out. There are some things to work out with this. I know NC State's looked at this in pre-ruminating goat kids. They use this predominantly for osteoarthritis in small animals, so I definitely could see this being used for some of our companion sheep and goats. But there was a study done with alpacas where they gave them a 2 mg per kg dose, and after that oral administration, they could not detect it in the blood. So it's probably not that well absorbed from the rumen, and we do not have an injectable formulation just yet. Some of the more potent drugs that we have for analgesia are opioids. We have regulatory concerns. These can be a little bit more expensive. What we use commonly is drugs like morphine, butorphanol. Now, bufene is one that we're doing some work with now. This is an older drug. There's been a little bit of work done with cattle. Wasn't in cattle the most effective analgesic, but I think that could be overcome with dose. The thing that's neat about now bufene is we use morphine or butorphanol. There's all kinds of paperwork we have to do because they're scheduled drugs. Now, bufene is only a scheduled drug in Kentucky. And so this is something that potentially could be used on the farm if we could figure out how to use it effectively. And we wouldn't have to worry about all that extra paperwork because there's not really a human abuse potential with this drug like there is for butorphanol or morphine. The opioids, one of the other ones we'll use in the hospital setting is fentanyl. The thing about fentanyl is you hear it probably about more in the news because it can be a very dangerous drug, and that's just due to how potent it is. We think of our opioids compared to morphine. Fentanyl is about 100 times more potent than morphine. So it means you need 1/100th the amount of fentanyl that you would morphine to achieve that same pain relieving effect. And that's why we typically will use this as like an IV infusion for an extended period of time or transdermal patch, because one injection is going to be so little of the drug, it's probably not going to be around that long, even though it's incredibly potent. So just to go through some of the opioids that we use frequently, morphine, we're seeing doses now like up to the 0.5 mg per kg. We typically give this pretty frequently. The adverse effects we worry about is ileus. And again, none of these drugs are going to be labeled for sheep and goats. It's all going to be extra label drug use. Butorphanol, we're using a little bit more and more. We do see sedation with butorphanol as well because it has agonist and antagonist properties. Fentanyl, we will see for very potent analgesia. We'll typically be using this after we do orthopedic procedures or pretty advanced surgeries. And the nice thing about the transdermal patches, if we put one of those on, we can get about 3 days of pain relieving effects with one patch application. So there are opportunities where even though the sticker shock might be a little bit high because the price, if we spread that out over 3 days, it works pretty well. The thing about the transdermal fentanyl patches, The application is key. And so like we like to make sure that the skin is clean. We like to blot it, but not really scrub it because we want to leave the oils on there and we like to protect it. I typically don't send animals home on fentanyl patches, although I've met a colleague from Louisiana that does. The reason I don't is just because if we have heat, that can lead to this drug being absorbed very quickly. So if we have an animal that gets in like a warm place, or if they got like a heating lamp or something like that on them, and there's also the potential for human abuse with this drug. So there's, people that'll take the patches and I think they cut them up and they chew on them to get a bolus of fentanyl themselves, and I don't want to have to deal with that. Typically, the dose we use is 2.5 micrograms per kilogram body weight per hour, and it takes about 12 hours to reach that maximum levels. But again, we have to be very careful with heat and the application security, just because if it gets too hot, it can be absorbed very quickly. This is kind of the process that I mentioned. The one thing that when I use these, we try to focus on doing is like labeling on there, like we'll protect the fentanyl patch with some type of film, whether that's elasticon or similar bandage. And we'll often staple it to the skin as well, just to hold it on there, because I used to use glue, but that doesn't work as well. We'll try to label it with like the date, when it was placed, and what the dose is, just in case there's any concerns. We know immediately how long it's been on there, and who put it on there, and have an idea when we'll have to remove it. We're starting to see other things like buprenorphines becoming a little bit more commonly used. And I think this is from our small animal colleagues that have in the clinic. It's kind of pricey, so we're not seeing this as frequently. There's been some work with the tramadol tablets, but it's not really recommended because they don't actually work that well the more and more we look into them. The thing about the opioids that's kind of nice is that if we get adverse effects from them, they can be reversed with things like naloxone. Naloxone, one of the brand names for it is Narcan. The thing we have to keep in mind if we reverse an animal with this is that they may need, they may need multiple reversals because naloxone half-life can be shorter than the half-life of some of the opioids we're trying to reverse. Butorphanol has some antagonist properties as well, so we potentially could use that to reverse sedation of our mu agonists like morphine. There's some other drugs that we use for pain management. Gabapentin is something that we use in people for neuropathic pain, for inhibition of the calcium channels as part of that neurotransmission of pain. There's some thought that if you give this with one of those NSAID drugs, you can potentiate the NSAID, or it'll work a little bit more effectively. And we're using this more and more. We don't have the best evidence for it, but we're doing a little bit of research with this drug as well, just to figure out the optimum dosing. And then ketamine is a dissociative anesthesia drug that we're seeing used for pain vacation. So if we have animals in chronic pain, sometimes we'll bring them to the hospital, we'll put them on a ketamine CRI, or we'll give frequent ketamine injections. And the thought here is we want to have some kind of event that will just break the cycle for pain. And we might do this for several days before we send them home. So for these multimodal therapies, often I'll think about combining, different analgesic drugs, and castration. We'll often use a local anesthetic, whether that be a cord or an intratesticular block. And then we might, give an NSAID at the same time, whether that's meloxicam or flunixin. Depending on the size of the animal, we might give some of these other analgesics or anesthetics as well, like ketamine or xylazine. This blooding, I still use local blocks, although the data for the local blocks with this blooding, is getting a little bit more divisive. There's some thoughts that's a little bit more stressful to give it than it is just to spud the animal. I do like to do an NSAID, and there was an interesting paper that came out recently that showed that one of the most pain relieving things you can do for a goat kid to spud them is to do it under gas anesthesia, which I think is kind of cool. It's just not very practical in all settings. For dystocia, we'll often use a local anesthetic in the form of an epidural, and we'll use a non-steroidal anti-inflammatory for both the dam and the kid or the lamb. I think we're going to answer our questions at the end there, and I know I have to get through a little bit more material before we're done. So from here, I wanted to transition to some of the tools for pain management. And one thing that I've been using more and more in the hospital is acupuncture, and this is the application of needles at specific sites, whether these are sites that have been identified through traditional Chinese medicine, or potentially we'll call trigger areas or trigger points that we feel when we palpate the animal. We don't know a ton about acupuncture, but we do know that when we put these needles in, the body produces its own opioids, and the production of this endogenous opioids will be increased. Microcirculation to the area will be increased, which if we have more blood flow, that could potentially lead to more drug delivery or more healing. And there's a huge body of work that keeps growing and growing in the small animal field that shows that we have faster nerve healing. This is a challenging therapy to study, just because it's very individual animal tailored to, and we don't necessarily have the ability to do that in a research setting. We're using electroacupuncture a little bit more, where we'll actually apply current to those needles, and the transcutaneous electric nerve stimulation units or TENS units are something we're using more and more too, and I think you can get a similar effect with those. You can do electroacupuncture. So various size needles, they can come coated in silicone, they can come uncoated, and depending on like the animal and what you're trying to achieve, we will use these. And so this is a case here, we're trying to use electroacupuncture in. We just palpate to feel where the painful stimulus is. One of the places we'll use is Ba Wei, which is a permission point that'll calm an animal. Excuse me there. And then we identify where we're going to place our needles. So for here, we're placing them on the bladder lines. It's not necessarily the name for traditional Chinese medicine corresponds to the where it acts on. Like the bladder lines are more for like the big spinal accessory nerves. And then we applied some electrostimulation to this. So this is the tool that I use. They're not terribly expensive. One of the other tools we can use for similar effect is going to be the transcutaneous electro nerve stimulating units, or the TENS units. Sorry, I'll just get to that. We're seeing these on Amazon, and the price on these keeps dropping and dropping. So instead of putting a needle into the animal, you clip the skin and you put one of these patches on. We're seeing other things where aquapuncture, or maybe instead of putting a needle, you place sterile saline or B vitamins. I don't have experience with chiropractic, but that's becoming more and more popular. So there's some other tools that don't involve drugs that we're using more and more. Regional perfusions are something that we're using more and more too, with local anesthetics, or maybe we'll place a tourniquet. For this sheep, we were taking a mass off of the foot, and we basically just put a tourniquet above the leg. We introduced this butterfly catheter, and then we put lidocaine in there. By putting the tourniquet on there, we kept all that local anesthetic in the foot region, and so we were able to dull the pain and remove the mass in a much more efficient manner than if we were just cutting it off or potentially using general anesthesia. We're seeing applied nerve blocks, or maybe we'll put a local anesthetic through an injection. And we might use like our ultrasound to guide where we're going to put it and get like some precision application. There's also in surgeries what they call splash blocks now, or maybe before we close an incision, we just splash a little bit of local anesthetic on there. Wound soaker catheters, we're seeing more amputations that we're doing, and these are kind of a neat thing where if we have to remove a limb, or if we have a very severe soft tissue injury, we can actually introduce a catheter with little holes in it, and we can put small amounts of local anesthetic in there. There's a study done out of Cornell that looked at multiple species, but they didn't find any increase in infection rates in animals that had these soaker catheters versus animals that did not in these wounds. And so they can be very easily made with just a red rubber catheter. You kind of melt the end over with a lighter and a pair of hemostats, and you put a whole bunch of little holes in it and a PRN cap on the end, and you can put this in the wound for several days. One technique that I've seen used, I don't have permission to use in the image, so I just tried to mock up best I could with a skull printing I had in my office, is placing catheters into like the mandibular foramen for fracture repairs. And like this was done successfully with an alpaca at the University of Saskatchewan, where they repaired a fracture but in the mandible, but the animal's jaw was so painful it wouldn't eat. So they actually put a catheter into that mandibular foramen where the nerve enters, and they would just periodically put local anesthetic in there, and they were able to get a decent resolution with that technique. Epidurals are a technique where we'll put like a drug directly into the space surrounding the spinal cord. And one thing that's got me excited for clinical applications is the epidural catheters. These have come down in price tremendously over the past few years. where this used to be a couple $100 to place one of these. You can get one of the kits for $37 now. And so if we have orthopedic procedures like an amputation, we'll be using these, and we can use one of these and place a catheter into that epidural space, and so we can keep the drugs going through there instead of having to repeatedly go in with a needle. And then just some quick things to wrap up with here are regulatory concerns. For sheep and goats, this is a listing of everything that we have labeled for their use for pain relief. The only thing we have is one topical anesthetic. Goats are the same thing. So none of the drugs I've talked about up to this point are labeled for sheep and goats in the US. And when we use a drug extra labelly in a food animal species, we do have to be concerned about extra label drug use. And we have to have a vet client patient relationship. And so there are some restrictions for that. When you use a drug extra labelly, we have to make sure we follow these things where it would be illegal to do. One of the things we have to do as veterinarians is provide withdrawal advice. We still have to do this with our pet animals, and I try to word this carefully. And one of the resources we have is FARAD. So at the University of Tennessee, this is the form that we use. We put the animal on here, we have a residue recommendation, we get signatures. And there's some additional resources for this from the American Association of Small Ruminant Practitioners, and they have a policy on small ruminants. They have things on the VCPR. And so a couple of things that I think are going to be exciting in the future before I'm done. We have a liposomal bupivacaine, which is a local anesthetic that's essentially protected by a bubble, and you can inject this into tissues.
We're coming to the end.
And it's
we could leave 10 minutes for questions. I apologize to interrupt, but we only have 10 minutes left, and I know that some of the folks still would like to have some questions. Sorry.
All right, well, I'll go through that there, and again, thank you for having me on here, and I'd be happy to entertain any questions that we have.
Thank you so much. It was really a good talk. I just tried to give people a little bit more time still, because we like to integrate some of the questions they have. And so if you do have a question for Dr. Smith, please feel free to enter it in the chat box. We will have this talk also recorded and posted on our YouTube channel. That will happen in the next couple of days. We have one question by Megan, and she asked, do you recommend offering something to help potential ulcers when the animals are on NSAID for long term?
And so the answer is for that one is going to be yes and no. If I think I'm seeing evidence of ulceration, I will. And if I have seen any of those signs, like if we see the tooth grinding or the food selection, sometimes we'll do a course of pantoprazole, which we know is pretty well absorbed under the skin. We just did some work with esomeprazole, and we know that's absorbed pretty well under the skin as well. But if I don't see evidence of ulceration or those behaviors, I try not to offer those drugs, because sometimes they need to be given long-term. In the human population, with those class of drugs like esomeprazole, pantoprazole, they're called proton pump inhibitors, and people that are on them for long periods of time do have adverse effects. So it's kind of weighing those benefits. I think that's a little bit different with our miniature pig patients, because they are very susceptible to ulcers from the non-steroidals, and some of them have very severe arthritis. And so those, I know that some people will put them on concurrently. But if I have an animal that is going to be on an NSAID long term, what I try to focus on is getting the least amount of dose that's going to give me an effective response. And that might be cutting the amount that's given every day down. That might be taking the amount of the NSAID and giving it every other day instead.
I muted myself. I have a question regarding the lidocaine use at disc budding, because you mentioned there are controversial studies at the stress of actually putting the lidocaine in versus the actually burning. Could you elaborate a little bit on that one?
Yeah, so some of the studies that look at cortisol, which is going to be that marker of stress, will find that the process of going through and injecting the local anesthetic or the lidocaine can be more stressful to the lamb or the kid than the disbudding process itself. And I guess I'm kind of on the fence on that. When I do this in like the hospital setting, I'll typically sedate the animals that I'm disbudding. and I used a spotting box. And I think when I do that, we kind of minimize the effect of giving those injections. But the local anesthetics, they can burn. And I think we've all kind of tried to wrangle like lambs or kids. And we know that sometimes their perception of what's going on is not necessarily, they might think there's more pain than what's actually going on there. But it's one of the things that's been unique in the research in that area is that, potentially giving this local anesthetic might be a little bit more stressful. But I still think that in the right settings, like if we use a little bit of sedation ahead of time, we can reduce that stress. I think having the local anesthetic is probably going to be beneficial for the animal.
On that note, I have another question. What about the post-disbudding analgesic? What kind of choice?
Okay, so post-disbudding, I like to use meloxicam if I can get it into a small amount into the animal. Typically, we think of meloxicam as being like a 15 milligram tablet or 7.5 milligram tablet, which if we're dealing with a kid or a lamb that's not very big, can be kind of hard to split those into quarters. Potentially, we could use flunixin in small amounts as well. But I think the one thing that, is kind of important to keep in mind is, we use those cautery disbudding irons, and that's going to damage the nerve. So it's not going to, be able to transmit pain as well. But we're still doing quite a bit of inflammation locally to those tissues. I think any type of anti-inflammatory we can put on board for a few days afterwards is going to be beneficial.
And then we have another question here. Do meloxicam or gabapentin start to lose effectiveness after long-term use?
So I think for gabapentin, on the human side of things, they often have people on that drug for long periods of time. I think there is some thought that there can be some like adaptation to it. I imagine with like the non-steroidals, I think it would like a meloxicam, I think it would come down to why are we using it long term? Because we'll see some animals with osteoarthritis that when we put them on, meloxicam, we're just trying to minimize the pain of that condition. That condition's not going to go away. So if we can slow down the inflammation or we can slow down the progression, but I definitely think with like our osteoarthritis cases, those are often the ones that we have to tweak after a few months or after a few years, because like that's going to be a progressive disease. So I definitely think there are circumstances where it might not be as effective, but for the NSAIDs, I don't think it's typically like adaptation. Like we'll see with like the opioids, we'll see tolerance develop, and I don't think we really see that with the NSAIDs as much as the condition we're treating will progress, and then we might need to alter our approach to them.
I think we have no more questions, I believe. If you do have another question, feel free to put it in the chat box right now. We still have a couple more minutes. Oh, we got one here. Could you make a recommendation for producers banding goat sheep?
So recommendation for banding, I think the key thing there is to do that at the appropriate age for like the device that you have. I think that one of the issues with banding that I've seen is that, sometimes people will use like a smaller size band on maybe a larger lamb or larger kid than what they should. And I think if we can stick to the recommendations, it's useful. The other thing about those, I think some of those cases can still benefit from pain management, but it's not necessarily, we don't necessarily see the issue right away. And I had an example when I was a resident, and it was actually, it wasn't lambs or kids, but we banded a whole bunch of calves, and the client normally would pick them up that day. Well, they couldn't come that day, so they had to leave them in one of our holding pens overnight. And when we applied the bands, we used local anesthetic. The calves all looked pretty good that night, but we came in the next morning, they were quite uncomfortable. And so I think with banding, one of the things to keep in mind is there's still going to be discomfort or potential pain for a few days or maybe even longer after we apply the band. And so potentially keeping an animal on like an NSAID or something like that for a little while longer could be useful for managing their pain. That's one of those things that I think for banding, that liposome would be pivocaine. If the cost would be to come down, could be a very useful tool, because essentially we could put a local anesthetic in there that would take away sensation for 72 to 96 hours if we could figure out how to use it appropriately and the cost came down.
All right. That was very good. Thank you so much, Dr. Smith, for your time and all the information. I really appreciate it. And the other questions I'm probably going to just copy you and send you, and we will answer them on a different way. Probably will post them on the Facebook page in the next day or two. If you do have more questions, please email them to Gold Coast Veterinary Service at gmail.com, and we will forward them to Dr. Smith. And otherwise, if you like, we will see you again in a month or so for another webinar. Please just check our Facebook page or social media for updates on it. And I will post this recording in a couple days, most likely. All right. Thank you so much, Dr. Smith.
All right. Thank you, Dr. Varga. Appreciate you having me on.
And have everyone a good and safe night. Bye-bye.